Hello. I try to speak properly. I lost my voice, but maybe I look at the screen here and then I can speak to you easily. Yeah, good evening, good afternoon, everyone. Thank you so much for the invite, and I hope I can share my journey with you and my cases with you and inspire you to do the same thing and then to try to cure the incurables through using the hyperthermia. And you should combine and do integrative medicine together to help the patient to come to complete response. So my topic is curing the incurables using the hyperthermia and inducing the abscopal effect with the radiation treatment combination. So I came with a case. We quickly go through this very interesting case, and then we should think along how we can help more patients to do this. This is a case with double primary cancer. It's very rare, but after the pandemic, injections, many people with injections, vaccines, they have very weak immunity. So you started to see double primary, even triple primary, 2 cells to 3 type of cells of cancers in one same patient. So I had one such case, and this is one out of the many cases that we have helped. This patient has 13 tumors in the whole body, and he has run out of options. He's an old guy, and nobody wants to do anything for him. And actually, he couldn't afford a lot of things. So he almost wanted to give up. And then since we know the patient for a few years, and after the pandemic, he gets sick, we continue to help him. So at the end, he got cured, and he became a complete response, okay? So this is a 67 years old man. The primary is a low-grade B-cell lymphoma, and he didn't go for any treatment anymore in the past 2 years. And then the disease slowly come back after the pandemic, and he has a very big squamous cell carcinoma on the face. And then the lymphoma relapse, left side and the right side of the neck. And inside the body, multiple tumors everywhere. So the treatment history is integrative, personal, precision treatment that we have done. I want to highlight to you this patient has done remission 1C for 80 hours. This is spanning from October last year, 9, to March this year, 16. So before, during, and after the radiation combined, that this patient has started hyperthermia. And the precision radiation used was the very special machine called the gamma knife, which is 5th generation, the rotating gamma knife called the gyro knife. It is done in Chongqing, about 10 sessions, 3 GY, 3 gray, 10 sessions. And that treatment is in October 18. So we have started 9 to 18 hyperthermia, then Chongqing, then November back, then hyperthermia until March, okay? So this is a patient with a very huge, you can see that this is a tumor here in the face and the neck, okay? And when the time that the patient come to us is very big and very foully smelling, and then in less than 1 month, we see very rapid tumor shrinking. And this is how big it is in June and July. We saw the patient in October, and he almost always wear a diaper on the left face. It's so huge that eye cannot open. And then he tried to do some own charcoal treatment. And when we wash it out, and the whole tumor is so huge, and you cannot open the eye. This is a SCC, squamous cell carcinoma. Upon the PET scan on the October 9th, you can see that this is lesions that is very big, full of sugar in the PET scan. And then this is October 9, we do the full body scan, PET scan. We have also discovered 10 more tumors everywhere else in the whole body. But the patient only have some budget to do the treatment to the face, so they do the face. And then this is the journey on October 18 to 11, November 8, around 10 sessions of the spinning gyro knife. This is what we call the spinning gamma knife in Chongqing. It's called a gyro knife, okay? And it's a very non-invasive, totally non-invasive treatment. And of course, we teach the patient to detox the body, take nutrition, take some injection to stimulate the immunity. And we teach them how to do some intravenous drip, including in Chongqing, they do herbal IV drip. And of course, we teach the patient to continue to do hyperthermia whenever he can. So this is the direct evidence of the tumor planning, that the radiation was given to the tumor in the neck. And here you can see very clearly, these are the tumor radiation shooting the tumor planning to the face, and then the left neck, and a little bit to the right neck, just to mobilize. So what happened to the patient is the first day of the radiation in Chongqing, no pain at all. And then 3 days later, the technician on the 4th day objected to continue because the tumor shrinks so fast that they have done the tumor field replanning. They have to shrink the tumor field. And then this is day 0, day 21. And then after that, no more other treatment. But the disease continued to shrink spontaneously. Okay, of course, the patients do the 5 things. Eat the right thing, detox the body, inject something to the tummy like a mistletoe, helixor, fraxini, imicotel, thymosin alpha-1, and then IV vitamin C, artesunate, B17, and then DCA, of course, hyperthermia to continue. So after we're done with radiation to the cancers, we treat the human body. So day 45, you can see the eye is open. Of course, he's happy, and he can move his neck very nicely. And then this is day 64, 69, very small lesion now. The left eye, you can see this become a handsome man again. And then up till April 13, we have the latest photo of this patient. So the squamous cell carcinoma, the first cell line, get a complete response almost. This patient didn't go through any more surgery. There's a 0 chemotherapy given. There is no tablet of TKI, no Zumab, maybe some low dose ICB, yes. We didn't do any other conventional hospital treatment because the patient gave up and is too old. So this is the left neck. You can see this is in my clinic, October 11 last year. And then this is on the November in Chongqing. And then 58, day 58. And then we repeat a PET scan in February 9, 6. So this is less than 120 days. It's 115 days. You can see the evidence of abscopal effects being widely observed here. This is a treatment field that the tumor disappeared completely. And then you can see this is the neck we do treatment on, the before and after in 115 days. The activity, the SUV is no longer there. So the volcano became dead. It's not that live anymore. So you can see February 6th, the axillary tumor, which we did nothing on, disappeared. And then these pelvic lesions, left and right, disappeared. So this is abscopal effect, proven, seen. And then this abdominal lesions here that lighted up, it's gone, became inactive as abscopal effect, again observed because these are the lesions that no treatment was done. And this is the evidence of October 9, February 6, the 12, 13 lesions compared, and there's a lot of improvement. And then the patient now is in complete response. One more look at this big skin tumor is clear. The neck before and after 115 days. This is the big neck area. The face clear. Huh? This is the face, it's clear. This is the neck, clear. Axilla, clear. Then this abdomen, clear. This is pelvic, 2 big lesions. Clear. My sonographer in my center, October 15, October 12, scanned the person, 6 cm tumor in the neck. After he came back on December 9 before the Christmas, I scanned and my sonographer said, "Doctor, what did you do? Where is the 6 cm tumor? It's gone." And then no more treatment done after that. The tumor, upon rescanning on the March, continues to reduce and disappear. Okay, this is the powerful abscopal effect once you can know and learn how to induce it. So this October 10th, December 9, the cancer marker, we do a mapping. Although he's a man, but we do the CA199 and CA125 because this is what we call tumor-associated antigen. You will do female cancer marker in a male patient. And don't forget to do PSA in breast cancer because breast cancer patient can express PSA positive as well. So we do a tumor mapping overall, and then we follow up on all the cancer characteristics. And this is the figures. The IVRA 491 dropped down to 2.9 to 6, SCC to 1.3, and there's reduction of all the other cancer markers. October, December, and February. This patient is alive and is happy. And he came to our center. This is Christmas Eve. Probably last year the best Christmas to him and to us as well. So our job is to get patients well again. And that's why we run the center. So I want to address to everyone here, we have to accept the desire in us, which is to cure the incurable. You see, curing the incurable takes beyond the limit of any medicine that we understand. And there are many books to teach us how to cure the incurable. And Dr. Thomas Levy talked about curing the incurable a long time ago, multiple books. So why the incurable get cured? Because we keep on heating the iron until it is hot, okay? But we need to thank God for the immunity that He has created in us. We have to continue to do the good work because God created us in Christ Jesus to do good work, which God is already prepared in advance for us to do. So God has installed this formula for complete cure in human. And that formula is called antigen plus antibody equals to memory. That means the bad guy, expose them. The good guy, let them come out. And then let them fight to have a fever. And then once they overcome it once and for all, they get cured. So what is abscopal effect? Abscopal effect is often seen when you do local regional manipulation of certain tumor. And then the benefit of healing completely at a lesion distant to us. So, but then we know this is very common and not rare. Many people think, oh, abscopal effect is a miracle, and it is not a routine. Nope. In our center, abscopal effect is a routine, not a miracle. And you can do the same thing as well. I hope I inspired you so that you do not delay the cure. You see, just now you saw the case. Waiting to be too old. Many times you see these cases. They're too old. And then why they are too old? Because they have finally run out of organ to cut out. And then they have failed line 1, line 2, line 3 chemotherapy. Then only we talk about non-invasive method or less invasive method. Maybe sometimes the old patient, no one wants to touch them anymore, that they are cured. So my reasoning to you is that why should we wait until no more option then we start the correct sequence? Maybe we should start with no invasion first. When it relapses, then only we do some minimally invasive procedure. And then if they really uncured, come back with the third times, then only we do a big surgery or something like that. Why must we begin with 重创, 大创, 才来微创, 才来无创? No, we should be the other way around. So abscopal effect is commonly seen, easily inducible, a routine, if you follow the correct sequence. So you do local regional manipulation of the tumor, you orchestrate to elicit the systemic full immune responses. So the global full body regressions is by the host immunity, not by the drug, blockbusters, all these things. And then it is outside the unusual sequences, And there's 5-fold principle to induce this if you can follow the flow, the steps. So the abscopal effects on the bone. So when was this discovered? If you go online and search abscopal effect, it's discovered long time ago. The 2017, there's this breast cancer 1 year, 4 year, 5 years later. Radiation to the breast area, and then metastatic thoracic bone area. The whole body, the lead, the bone, the lung, the bone get healed 2 years later. So this year 153 from 130 to normalize. So immunologist is badly needed in cancers. We have to use the immunology in human to heal the patient, because God created human with immunity. So follow the rules, which is antigen, antibody, memory. So if you can overcome the cancer like a flu, you will never get the same flu twice. So we need to harness into the innate and adaptive immunity. We have to teach the patient to reject the cancer once and for all, to induce cancer abortion globally. That means we became an abortionist doctor. We try to teach the patient and help the patient to have cancer abortion. Okay, so to reject the cancer spontaneously. So the grand simple goal is to develop a lifelong cancer rejection immunity, which is an immunity that rejects the cancer lasting long time, a lifetime. So abscopal effect in 2018 has been discovered 60 grade to the right breast, to the left femur, to the lumbar. And then what happened? The whole body looks like this, heals completely. Okay. So cancer is actually an antigen problem. It is cunning and is hidden. Many people keep chasing the cancers, but we do not understand the cancer is an immune antigenic problem. Tumor is poorly seen, it's not obvious, it's hidden, it's cold. The body unable to reject the foreign body. The immune system and the weakened immune system is corruption. There's a lot of T cell exhaustions. That's why we need neoantigen exposure. New antigen to be presented to the human body. And the body is inability to have fever. Many cancer patients did not have fever effectively the past 30 years. So many cancer is hidden. The 80-20 rules, the TAA is hidden, like an onion, like a socks, inverted socks. So we can turn the cancers inside out and expose the tumor. So every tumor is about 10 to 20% cancerous, 80% healthy cells. So we want to only kill the cancer cell, expose the neoantigen inside there, and then present it to the surrounding neighbor, good neighbor, and the neighbor will present and blacklist to the rest of the whole body for cancer rejection immunity. So our focus is how to induce this relapse-free complete remission, that we have to firstly believe in our hand that we would be able to revive. So this is a cancer. We need to understand the cancer 80-20 rules. Many cancers have a lot of antigen wrapped and hidden inside. There are many good cells and bad cells, whole and hidden, and then bad cell ransoming the good cells. So it's like a crime terrorist village that we have to be smart to catch the bad guys. And there are 3 tumor zones that we need to know: the immune desert, the immune excluded, and the immune inflamed. This is a hot tumor, this is a cold tumor. We need to learn how to convert the cold to the hot tumor. There are many different methods that you can search online, how to turn a cold tumor into the hot tumor. And we need to understand the tumor that is present in a human, the first level is in the tumor itself, called the cancer sons and daughter cells. The circulating cancer cells is in the blood, which is 6 liter. This is the cancer stem cell, the father cells, and then the great-grandfather cells, which is hiding in the lymphatic. And this is the tumor with metastatic side, primary side. Cancer likes to hide in the tumor, the sons and daughters. And then the fathers and the mothers circulate in the blood, which is 6 liters. That's why it's difficult to treat and cure the tumor if you fail to recognize. After you cut the tumor away, they can be tumor-free but not cancer-free. So you need to deal with this MRD, minimally residual disease there. And then the worst is the king cells, the cancer stem cell. The embryonic cancer stem cell hides in the 20 liter of the blood of the body compositions, which is outside the cells and in between the blood vessels. This is what we call the body fluid. So the 20 liter plus the 6 liters, 26 liter cancer stem cell is present in having a lot of a cancer stem cell that we need to deal with. And hyperthermia is an all-rounder to kill all of them. Now we need the antigen to be exposed. There are 3 types of antigen: the tumor-specific antigen, tumor-associated antigen. But these are weak antigen. I am talking about the most useful one is the neoantigen. The neoantigen is personalized inside the tumor itself. No 2 tumors are the same. Okay, no 2 tumors are the same. No 2 breast cancer are the same. No 2 prostate cancer are the same. Every human inside the tumor, there is a lot of opportunity of you chopping off the tumor big time and expose the neoantigen, 新抗原。新抗原的刺激和释放是很重要。And this is meteor. Our goal is to have a meteor rain showering presentation of the neoantigen to the prepared body, clean up body. So what is the neoantigen like the ATP, exon 1 tumor antigen? It will stimulate the type 1 interferon, the high mobility group box 1 protein, and all the rest of the messenger here, heat shock protein 70, 90. These are all the cascades of a cytokine that is able to trigger the whole body to cure the cancer once and for all. And this is the Abscopal effect, rules and regulation. And this is the secret to induce the Abscopal effects through the neoantigen process. So teaching the adaptive immune system to see the antigen, present the neoantigen to the already stimulated, preserve and reserve and conserve T cells and the B cells, and let them multiply, going through a clonal expansion, selection, and then multiplications of the T cells memory and the B cells memory, translate them into the adaptive long-term plan. So initially the antigen is here, the T cell will be coming out. The T cell contraction will not stay 0, and then there will be cross-talking that is very important. So hyperthermia would be very useful here, here, and here, the cross-talking as well. Please give the patient 20 weeks to 30 weeks chance to develop this lifelong cancer rejection, tumor abortion ability, the immunity. So what the key here is how can we induce immunogenic cell death, the ICD. The ICD is by oncolytic virus and precision radiation and hyperthermia, or intratumoral injections, or HIFU, the focus ultrasound, very focused, only killing the tumor and not the human. So after you induce the immunogenic treatment, then the cancer will break, only the cancer cell break into big fragment, and especially oncolytic virus would be able to expose the tumor gene, break them down and expose all the neoantigen, and it will cascade and stimulate the whole body. Now pay attention here, we want the immunogenic cell death. If you are not careful, you will lead the patient into tolerogenic cell death. The tolerogenic cell death is the M2 macrophages, which we do not want. The Treg cell will come out. The MDSC, the myeloid-derived suppressor cell, will be very highly elevated. So we want this on the left side. Photodynamic therapy, maybe oncolytic virus is helpful. And precision radiation such as cyber knife, gamma knife, proton beam, very helpful for this. Releasing and breaking down, releasing all the neoantigen. And pay attention here because we do not want the tolerogenic cell death, because we want immunogenic apoptosis. We do not want the tolerogenic apoptosis because the immunosuppression immunity would be overdosed. If we are very careful with selective killing only the cancer and not human, then we can develop the tumor rejection immunity lifelong, leading to the relapse-free complete remission. That is the lifelong cancer rejection immunity. Oncolytic virus is very powerful. Infection, replication, cell lysis. It would directly kill the tumor cells, modulate the tumor microenvironment. This is a TME control. Number 3 is to systemically kill all the cancer cells, even in the blood, 6 liter, and the 20 liter lymphatic. And local drug response as well, because many viruses, these are the smart viruses, engineered virus, detox virus, that has carrier protein inside there, that's going to kill the cancer cells and leave the good effect there. These are not the oncogenic virus that human release. We are talking about the smart virus that you can use. So how does that work? There's a first generation virus, second generation virus, third generation virus, and the fourth generation virus as well. That the virus is merely just a VV, virus vehicle, double V, virus vehicle. And what is inside there is an important messenger that you can, for example, install the restore and reinstallation of the interleukin 12, 15, and then PDL1, that you do not need to give even this drug, that the human host is sensitive and produce their own. For example, in viral gene VG161, oncolytic virus in refractory hepatocellular carcinoma, which is in phase 2 and phase 3 trial now, you will create the tumor in situ vaccination effects that you can inject into the tumor, and then lyse away the tumor and release all the tumors in the whole body, and then it will trigger the rest of the whole body rejection immunity. In situ vaccination evidence of abscopal effect. I would like to inform you, if you do intratumoral injection of one tumor with VG161, you will see the other tumor having even more TIL, tumor infiltrating lymphocyte. And the other non-injected, non-treated tumor have even more infiltrated immune cells. The repair of the distant abscopal effect of the tumor is even better. Okay, so you can do intratumoral injection of oncolytic virus, or intra-arterial infusions, or the rest of the leftover in the bottle you can give intravenous as well. This is a patient refractory to tumor treatment with the intra-arterial infusion of oncolytic virus, that the tumor shrink almost instantly. Sometimes there is pseudo progression, but majority of the patient always went into tumor lysis and tumor regressions. And this is a comparison of VG161. The percentage of effectiveness is 100% better than this pembrolizumab, regorafenib, apatinib, and the rest, Merck, apatinib. This is comparable with second-line drug, even the second line and the third line. So why would we wait, if it is so effective even in the third-line treatment, why would we wait until we fail the first and second line? Oncolytic virus can be used in the first line as well. Very useful and safe. It has been approved in China 2003 and 2005. More than 22 years being approved already. And it is absolutely useful in ascites management, that you can do intrapleural infusions and intraperitoneal infusions as well. Intraperitoneal, ascites, and influence. So you deliver the cells, the virus kill the cancer, spread the virus, and the virus will last for 12 hours. Yeah, and disease control. And then this is conventional method. So I'm talking about reversing the sequence of treatment rather than follow the surgery, radio, chemo, immuno, NK cell. Why don't we do the hyperthermia and put the cell, put the immunotherapy, oncolytic virus, precision radiation, let the tumor shrink. If you relapse, then we do the chemo. If you relapse the third time, then we do the surgery. I think this would be so much more tolerable for the patient. Maybe you see the Mona Lisa from the front. She looks like a woman. But ever since 20 years ago, I started my clinic, I started to do reverse way of helping the patient, and I saw the Mona Lisa from behind. Actually, she looks like a man. Maybe you look at Mona Lisa from the front. So this is me. What is any other method to induce ICD, immunogenicide? This is CyberKnife. This is HIFU. This is tomotherapy. This is LINAC linear accelerator from the Varian. This is gamma knife. This is rotating gamma knife, gyro knife. This is proton beam. This is the heavy ion therapy system. And in China, there is the BNCT, boron neutron capture therapy. So how do you successfully develop the immunity for cancers? First of all, you ask, where's the cancer? The solid and the liquid, you locate them. You make them obvious, stimulate them, make it, visualize it, sensitize it. And then you ask, where's the host immunity? Please don't destroy it. You have to stimulate the host immunity with the sagramostim, sagramostim or filgrastim, stimulate the sagramostim at GM-CSF, and then let them fight, expose the tumor to host immunity. Let them fight and carefully and allow them to have fever 3 to 4 hours, and then create a crosstalk, which is the fever. We want to help the patient to blacklist the cancers and to last the memory a lifetime. So if you cut and throw the tumor would not give you any more neoantigen. Rather keep the tumor in the body, do something to the tumor, low dose radiation, trigger the whole body systemic attack, and then create the in situ tumor vaccine. By, I think everyone here, if you are seeing cancer patient, don't be afraid to hold the cancer in your hand, the tumor in your hand, and start to deliver and inject many items into the tumor, or regionally the lymph node, and then do the IV. That's going to be very helpful for the patients from the tumor, the blood cancer stem cell, and the lymphatic stem cell. So turning the cold to the hot tumor is important. This is a cycle that you can download from CRI, Cancer Research Institute. Kill the tumor, release the antigen, send them to the lymph node, recruit the systemic immune response, allow the trafficking of the immune system back into the new tumor, which is hyperthermia. So hyperthermia is an all-rounder here that you can do from killing the cancers and induce in ICD, immunogenic cell death, presenting the cancers, heat up the lymph node as well. The 2-inch you can do. The 3-inch you can do the axilla. The 4-inch, don't forget to do the thymus. The 5-inch to the inguina, the 6-inch to the tummy. There are 5 probes there that you can fully utilize anywhere. That you can only kill the normal cell, kill the cancer cells and spare the normal cells. Hyperthermia is suitable for all kinds, any kinds of human cancers ever discovered by human. And this is a very special machine that I use thanks to Edible Lab, the Korean. And we started to do a lot of NK cell activity. Many of our 10 to 20 sessions of remission 1C patient, they increase the NK cell activity up to 1,500 to 2,000. This is a real one. I used to think this is not real until I do it on my patients. Yes, 12 to 20 sessions of hyperthermia systemically will increase the NK cell activity up to 2,000 times. When you do hyperthermia, remember to do directly to the tumor and the thymus and the lower limb. Okay, it's very important to do the whole body systemic, I know. So conclusion is abscopal effect, you can induce it. You conserve, reserve, and preserve the immunity. Give in the PD-1, PD-L1 low dose. Give the fever thermogenic IV colis. Give them the hackles. Give the cyber knife. Give the precision radiation to release neoantigen, okay? Rebuild the bone marrow. Don't hurt it. Replenish the NK cell and let the patient to go through the CBNK, cord blood NK cells. FMT, full microbiome transfer. 肠道菌移植是很有效果的。And then this is 5 methods to stimulate the immunity, low dose ICV, colis vaccine, hyperthermia, so that you can reverse the poor immunity, lack of fever, cancer is hiding, the devastated bone marrow and thymus, you can reverse that. Give them the cell therapy, no problem, DC, even give the cells. This is a cord blood NK cell therapy that I used to purchase and order from Japan, and we fly patient to China, we fly patient to Taiwan, we fly patient to Japan to receive this as well. Don't forget, these are the common 7 methods to help all patients: oxygenation, immunomodulation, non-toxic cancer therapy, give them good nutrition, microbiome restoration, and detoxification. Let me tell you this. Every cancer cell is sensitive to vitamin C, artesunate, B17, DCA, B15, high dose selenium, imicotel, curcumin. Every human cancer patient needs the hyperthermia. There is no human cancer that is resistant to heat therapy. Thank you, IVRA, and we continue to fight. Thank you for all the rest of them who allow me to visit and grow together with them. It's been the maybe 4th time or 5th time ever since I joined 5th. Now it's 9, I think 5 times already. So from palliative care, we can move away and we can move our thinking shift into complete cure. It is not rare. We can turn the situation around. And in our brain, we must be able to hit hard on complete cure, leading the patient firstly to the complete response. Thank you very much.
We are 10 minutes behind of our schedule, so let me now give the floor a chance to ask question. Yes, Dr. Kim Ui-shin. Please deliver the mic to Dr. Kim.
Thank you very much for very stimulating, good talk. You show clearly abscopal effect by the hyperthermia on imaging. Now, decrease FDG basically means just a less utility of glucose analog. So it seems necessary to get an immunological sort of proof by at least checking lymphocyte or some CD8 from blood or tissue, or beta interferon for cytokine things. So you have any such data?
Yes, in our center, we always do the lymphocyte subset. We always take the full blood count and we check the lymphocyte, the white blood cell, then the lymphocyte. We send the lymphocyte for lymphocyte subset. From there, we can see the pan CK cells. We can see the pan CD4, CD8. We can see T helper cell, T cytotoxic T8 cells. We can see NK cells as well. We can even see the monocytes as well. So these are the evaluations. And then we do the NK cell activity, and we have these immunological evaluations. But however, the cytokines, that the tests are expensive, and we did not follow up on all those cytokines. But of course, the very common thing that we do is chest X-ray to see the sizes of the tumor, if any. The ultrasound, although we know the FDG is low, the volcano died down, but we also scan the sizes and follow up on the sizes. And thank God this patient is still continue to shrink the tumor, maybe left with one lung tumor, that's all. So we are very happy for this patient, and this patient is the inspiration for us to continue to reproduce the abscopal effect in all the cancer patients.